Show the simple one and let us see what simple I can show. Gentleman, 63 years old, smoker, hypertensive. 63 years, male, smoker, hypertensive, diabetic, dyslipidemia, CKD stage 3B, EGFR is 38, and Menon score is 16, and development chances of development of C is approximately 57%, and diagnosed as non-STEMI. Angiography was done in a different center, and his ejection fraction was 45%. Creatinine was 1.7, and this was the angiographic findings. This was the angiographic findings. Distal left vein, critical lesion, and right coronary artery seems to be non-critical lesion, only minor ones. Angiography reveals single vessel disease involving distal left vein bifurcation. Syntax score is 18. And what should be the preferred technique and how we will proceed to treat it. Simple or complex LM bifurcation standing strategy selection depends on size, length, and distribution of the vessel, lesion severity and lesion length, anatomical complexity of the side branch, as well as disease extension, multiple bifurcation, angle, calcification. However, we do not have yet universal definition of what is complex and what is simple bifurcation lesion. As we know, all Madina classification and regarding as per definition 2 criteria, we can categorize the simple lesion and a complex lesion if the side branch involvement is less than 50% narrowing and the angle is less than 70 degree and lesion length is less than 10 millimeter, then we usually will call it a simple lesion. If associated with the angle is more than 70 degree or less than 45 degree, or there is severe calcification, or there is thrombus, then we consider if two of these criteria includes, then we consider it as a complex lesion. Operator experience in performing and optimizing any left main bifurcation lesion approach is more relevant than the specific technique of selection. And ultra low contrast angioplasty, as we know, there is chances of seat is much less with ultra contrast low angioplasty. And you see one study showed that incidence of contrast-induced AKI is approximately 0%. And what are the indication of ultra low contrast PCI? In the morning we have seen from National Heart Foundation Hospital and Research Institute, eGFR is less than 30 or serum creatinine more than 1.5 milligram per cell, eGFR less than 45 with patients more than 75 years of age, LV ejection fraction less than 50%, diabetes, hypertension, myocardial infarction, anemia, hematocrit less than 30. These are the suitable candidates for ultra low contrast angioplasty. And we have decided to do it with ultra low contrast angioplasty, and only one view left panel is taken. How we select the guide into the ostium of the vessel. After by seeing the movement of the guide, number one. Number two, after engaging the guide, we give intracoronary saline and we see that there is a ECG change. We are sure that we are in the ostium of the main vessel, either at main or right coronary artery. And accordingly, then we proceed. Here we have taken one view for control, and we have pre-dilated the lesion. How I have pre-dilated the lesion? Inflating the balloon, half the dia of the balloon, progressing towards the left main, distal left main. Whenever I felt obstruction, then I have deflated the balloon, and further going forward, I have inflated the balloon, and this way I have pre-dilated the lesion. And after pre-dilatation, we have done this intravascular ultrasound, and which shows distal left main is approximately 4.90, and the lesion length is only 8 millimeter, involving the distal left main, only 8 millimeter. And guidelines for recommendation of others, as we know, it is all groups like ESC or SCC class 2A indication. But for ultra low contrast, it is mandatory. And stent placement, so as because 8 millimeter lesion length and left main is another 8 millimeter, so 8 plus 8, 16, and another 4 millimeter distal to the lesion in LED. So we have decided to take 20 millimeter long stent and distal dia is 4. So we have decided to take 4 into 20 millimeter stent. And here at this moment we have given another cusp wire. Though usually we do not give it, but as because here we are doing with ultra low contrast, that is why we have taken one wire in the cusp root, and then we inflated, and by repeated stent enhancement we push dilate. On the right panel you see there is significant narrowing in the ostial portion of the LED as well as distal left main. And so with this stent enhancement on the left side, left panel, on the right panel we have dilated the distal part, as well as on the left panel stent enhancement, and in the middle panel a bit higher balloon 4.5 into 8, and we have post dilated. And then after this post dilatation, we once again, second time, this is the second time in the vascular ultrasound, after post dilatation, there seems to be malposition and some under expansion in the distal part, in the LED part, as well as in the left main part. And that is why we have once again, with the stent enhancement, we post dilated the distal part of the stent, and as well as the ostial part of the stent by balloon taking 5 into 10 millimeter balloon, and we have done adequate post dilatation. And then once again I have done, this is the third time intravascular ultrasound. It is the problem for doing several times intravascular ultrasound, and this intravascular ultrasound this time shows that there is well opposed stent, as well as area is also left main 17.46, and LED ostium is approximately 16.32. These are the MSC, and so we have gained the area what we need, and this is the only one final view. Initial view 4 ml dye, and this right view is another 4 ml dye final view, and this is the final result. And we all agree that left main PCI needs good clinical indication, good experience, procedure planning accordingly to lesion characteristics and complexity. Good lesion preparation is essential for a complete stent expansion and apposition. Stepwise approach, whether it is simple or complex, is till now superior. And intravascular imaging guidance for procedural planning optimization is essential in all cases of left main preferably, and particularly in case of ultra low contrast PCI, it is mandatory. And the provisional approach should remain the philosophy of choice in the majority of left main stem through bifurcation procedures. As we know, this year in EuroPCR, EBC main 3 years report, they have shown that the instant stent restenosis is double in case of double stent strategy than in case of provisional single stent strategy. Ultra low contrast PCI minimizes contrast-induced nephropathy in complex PCI of CKD patients. Thank you for patience here.
Thank you, Dr. Mir Jamal Uddin, for your nice illustrative case showing how IBUS guidance